Okay, so coming to the second point, and this fairness in allocation of organs. As you mentioned, probably ideally would be a centralized system where a central computer allocates the organ as numbers, and those numbers become patients. So after we identify which is the number 40 or 82 or whatever. Well, probably Romania is going towards such a system. So far, since in some areas like liver transplantation, heart transplantation, lung transplantation, the program here started at a very small scale. Was quite clear that it doesn't make sense to have a central system of allocation. But now that the number increased and well, this becomes a real problem, one good solution would be such a centralized allocation. Even more, and I must say that I see as a very positive initiative of the current ministers of health. It's a closer and closer relation with Eurotransplant, with the idea maybe in the future to join Eurotransplant the same way as Hungary did. And then Eurotransplant, of course, will allocate the organs. What I noticed for the time being, there was a fair number of lungs that were never used in the Romanian system of transplantation, which has a lung transplant program now, but very small. So those lungs go into Eurotransplant, and the patients across Europe are getting transplanted with lungs from Romania, Romanian donors. Same with some hearts, because also heart transplant program is not a very big one in Romania, and some of those hearts go into Eurotransplant. Therefore, this could be a way that gradually Romania may join Eurotransplant, and once we will be there as part of Eurotransplant, the allocation will be quite clearly a centralized one. What do you think about such a vision?
I think it's a very important vision to bring forward. Croatia comes to mind. That's why we've been with Mirella in these previous visits as a member of Eurotransplant. And I think her experience would be helpful in reflecting upon the vision that you've just elaborated. The principle is the important one of a centralized, computerized system of distribution of organs, that the people of Romania know that organs are being fairly distributed, and they can trust the system. Now, Eurotransplant brings that kind of experience and a verifiable system. So I think it's an important one to consider, but it wouldn't be for me to make that sole recommendation. I think the principle is the important aspect to consider at the moment, and that is the development of a computerized system in the distribution of organs, so that no one has the misinterpretation or misimpression that because of someone's stature or wealth or fame, they are being afforded an organ and disadvantaging another individual in Romania. Now, there's another piece of having such a Eurotransplant system, and that is the opportunity of efficiency. So not everybody can get a lung transplant in Romania, but lungs that are recovered, perhaps they can be transplanted to Romanians in Austria, right?
Hungary did this, yeah.
This is a kind of opportunity. Similarly, if you join that system, organs should be available from other members of Eurotransplant for Romanians to get liver transplants in Bucharest. So all of these elements have to be examined to have the vision that you've elaborated to be fully implemented with the proper concern for Romanians to be addressed. The principle is to have a computerized system that there's a trust of the people in the distribution of organs. There is experience within the Balkan region, for example, Croatia, that have found this to be a very good system. And my advice would be to engage those that have had the experience of Eurotransplant to get their input and determination of that vision.
What do you think about deceased donors as a way to increase the number of donors finally?
Well, deceased donation, when it comes to heart and liver and lungs, is essential. Clearly, living kidney donation provides a better outcome, but it depends on the age of the donor and the circumstances of the death, that kidney transplantation from the deceased can be just as effective as living donation as well. And of course, the living donor having a preponderance of organs coming from the living donors puts a burden on the well-being of individuals who become living donors, that there is a very small, but there is a complication rate, and there is a mortality. Internationally, it's perhaps 3 in 10,000 that may die as a result of being a living kidney donor. I think that deceased donation becomes a central part of a transplantation program. And as it pertains to heart, lung, and liver, it is truly essential. As you know very well, Irinel, as a professor, that there is a complication when it comes to living liver transplantation, that it may be as much as a complication rate, maybe 25%, may have some kind of complication having been a living liver donor. And there's also a mortality greater than what is experienced with kidney, whereas it's 3 in 10,000, it may be 3 in 1,000. So it depending on where you are, for example, in India or in China or Japan, there is a complication rate and a mortality rate that is an important consideration. So to answer your question, the burden that is being placed currently on the living donor can be lessened greatly, certainly in a country such as Romania, and has been again experienced in Croatia. There's a limited number of living donors. They've achieved a national self-sufficiency by deceased donation. And one other point that we've mentioned in our recent correspondence, they're moving soon to donation after circulatory death as another approach of increasing deceased donation. So having an experience of organ transplantation for nearly, 40 years, I can say to you that deceased donation is an essential element of a successful transplantation program, particularly for a country.
Right, and inside deceased donation, you already mentioned this circulatory death, which is a special category, non-heart-beating donors, and could be important in the future. So to have it in Romania, we don't have so far non-heart-beating donors in Romania. But we do have special procedures like split liver. When the liver is perfect, we can split it for two recipients. We use also quite a fair number of marginal donors lately, based on also on the liver assist machine that we do have. What is your opinion about non-heart-beating donors as a way to increase donation?
Non-heart-beating donation is now 20% of the experience in the United States. So it is a very important adjunct of increasing deceased donation in a circumstance that we did not have before. Countries such as Sweden, I've been for the last several years involved in the development of a DCD program in Sweden. There are now 6 pilot hospitals that are underway. My recommendation would be to establish at least one hospital that has interest. Now, again, it goes to the critical care doctors. And the importance is the following of the clinical situation. For everybody listening, an individual that has a devastating brain injury, but is not determined to be brain dead because they still can trigger the ventilator. there is a prognosis that is established that this patient cannot be restored to consciousness. And with that prognosis developed and the family's consent, it becomes end-of-life care, that the ventilator can be withdrawn. It's ethically proper because the treatment becomes futile. This is now an everyday experience in the United States. As I say, it's 20% of donors throughout the US. And in my region in New England, it has become 35% of our donors. So it provides hundreds of transplants that we wouldn't have been able to do. My recommendation is there's certainly the expertise of this approach is available and doable, accomplishable in Romania. And I would suggest that the national agency explore that possibility with at least one pilot, perhaps two pilot hospitals that would then bring forward DCD. The system is well established as to how this is to be done. Again, my experience in the development of this recently in Sweden, and we're now proceeding in Croatia, is one in which I would be delighted to make that effort and help in its establishment in Romania.
Okay, then let's talk a little bit about the second category, the living donors. The living donors, you mentioned already some of the problems related to the living donors. What is the dimension now, currently, of the death rate among those donors, which was the main obstacle, I would say, in front
So
of
there's still a death rate. As I mentioned, for kidneys, worldwide, it would be about 3 in 10,000, right? Mm-hmm. And for the liver, you would know as well by the international experience, as you attend international symposia and conferences, it is a greater rate of death, and it's certainly a complication rate. So there's quite a burden. In a country like Japan, there's 120 million people in Japan, or in Korea, where the preponderance of their experience is now living liver transplantation. In Japan, they only have perhaps more than 100 deceased donors, again, in a country of 120 million people. So they do their liver transplants by living donors. Or if they don't have a living donor, some of these patients come to the United States for a deceased donor. The culture has no objection, to receiving a liver transplant from someone who's died. There's no objection to receiving one, so I don't accept a cultural objection to having deceased donors as the basis upon which there's a very poor experience of deceased donation in that country. My view of this is just as what the World Health Organization has put forth. Yes, living donation is an important component of a successful program of transplantation, but the transplant programs have a responsibility. The country has a responsibility in trying to minimize the burden to the living donor by providing as many deceased donors as possible.
Right. So, on the other hand, everybody accepts today that the living donor is a good source of organs when there is available such a donor. On the other way, I would say that exactly like in the hospitals, you need a certain donor culture, a certain culture of donors, so that everybody knows what is a donor, how to deal with a donor, and things like this. Similarly, you need a certain culture of living donation and living-related transplants. And I would say that across the globe, there are not many countries in which there is such a culture. Probably there is Japan, as you mentioned, there is Korea, maybe there is Turkey, but not many others. So what do you think? Should we promote more the living donation? And
now this is a personal view, so I'm not speaking on behalf of the WHO or any organization, Transplantation Society. This is personal. I'm concerned about promoting living donation because there's a risk of complication. albeit small, but there still is a risk. If someone wishes to be a donor and they are informed of the possibilities of complication, what that may be for them for the rest of their lives, then I don't have an objection to someone being a donor, not at all. Because as you say, it's a very well-known opportunity of successful transplantation. But I don't see us being advocates per se of living donation when we should be advocates of deceased donation and making sure that every opportunity within a country is maximized rather than putting the burden onto the living donor. Now, that's a personal view. I think society has an obligation to maximize deceased donation. Moreover, I don't think that the living donor worldwide is adequately monitored in follow-up. So if you go to Turkey or to, as you mentioned, Japan or Korea, I don't know how, we don't know of reports regarding the well-being of the donors years later. Certainly not in India, which is doing several, 6,000, 7,000 living donor transplants. I know for certain that there is an unawareness of the outcome of that living donor, certainly in the long term. And there is a rate of renal failure that occurs in the living donor. So again, from a personal expression, I think we need to be maximizing deceased donation and not being advocates of placing an individual in harm's way.
And final question. So what do you think is the chance to have in the near future organs prepared from the patient's own cells, printed organs?
Yes, I'm smiling because it's a wonderful scientific adventure. But I don't know in our lifetime we're going to see that fully realized. Xenotransplantation is underway, and the genetic manipulation of pigs makes that more of a realistic possibility in the near future. But even there, I don't see its widespread distribution. I think we have a great opportunity yet of deceased donation to be realized that's not being done. And we can serve our patient population the best by seizing upon that rather than to foretelling that someday with stem cells and with printing that we'll have replaceable organs. I don't see that happening anytime soon. So it still takes me back to deceased donation as being a very strong proponent and saying to the country, there are systems that can be put into place that can help the patients of Romania very quickly. Before this year is out, this could be done. And I think it's an alliance that we must realize with the national agency and the new leadership there. And I'm certain that they're keen to do it.
Well, Frank, thank you very much for your kind support along the years, for all you did for the Romanian transplant. I thank you very much, and we are looking forward to have you soon here in Romania. Get well, because I know about your spinal problems and spinal surgery. Get well soon and come back in Romania, and well, please be as supportive as always.
Ionel, it's a great pleasure for me to be involved. I respect you greatly. It's always been a wonderful endeavor to be in a program with you. Having visited your hospital, I know the great contribution that you've made through a career effort there. So it's for me to commend you, and it's an honor for me to be involved in our conversation today and to wish you and the people of Romania well and eager to contribute as we go forward.
Thank you very much, Frank.
Bye-bye now.
Bye-bye.
Thank you.